I have the great pleasure to present you another study which was supported by Pierre Fabre, which is about visible dermatosis. You will see that as a dermatologist, we have to face a lot of skin disease with visible localizations. And it is something which is very important for the patient to know about, because these visible lesions on skin are considered by the patients themselves as very harmful, and they are associated with a lot of lack of esteem from the patient, a lot of impaired of quality of life. And so I will present you the data from this beautiful study, Visible Skin of Disease. This one. In terms of methodology, why this study? We know that, as I presented you before, that skin diseases have in common that they are often visible. And visible skin disease, which are skin disease with visible lesions, and you will see that many of them are located on the hands and face, alter the self-image of patients who suffer from them. And they can also be associated with very severe narcissistic harm from the patient who has them. In other words, an individual with a visible skin disease may feel worthless, uninteresting, ashamed, and self-reproachable. An individual with a visible skin disease may even lose self-confidence to the point of questioning his or her own personality. So the aim of the visible skin disease study was to assess the prevalence of skin disease with visible lesions, in other words, visible skin disease, in 8 emblematic skin disease, and we'll discuss about it in the next slide. The other aim of the VDS study was to evaluate the handicap and the burden of the patient with these 8 emblematic skin disease on multidimensional aspects of subject daily lives in respect to their location on visible body areas versus non-visible areas. In other words, we will also focus on face and hands with the results. So just to simplify the methodology, this is a population-based study in a representative sample of 6 countries around the world: Canada, China, Italy, Spain, Germany, and France. In this population, 8 emblematic skin disease represented by acne, psoriasis, eczema, vitiligo, ichthyosis, chronic hand eczema, rosacea, hidradenitis suppurativa, which represent more than 50% of all skin disease, have been studied. All participants were asked to complete a questionnaire to declare if they have a skin disease. All respondents with a skin disease were asked to specify the location on the disease on the record, and to complete a DLQI questionnaire. And across the respondents with the 8 selected skin disease, they were asked to complete a specific questionnaire which was evaluating the impact of the skin disease on their daily life, their professional activities, their social relations, emotional and intimate life, leisure, sports activities, and perceptive stigma. The first results were about prevalence and location of VST. In terms of prevalence, we have more than 13,000 respondents, and among these respondents, 26 of them declared a skin disease. Among these respondents, 23% of them declare having one of the emblematic skin disease, and among the respondents, approximately 17% of them have visible location of skin disease. In other words, visible location of skin disease are frequent and concern more than 1 individual in 6 in the general population. Among the 8 emblematic dermatoses, 3 out of 4 patients report involvement of the face and or hands. 2 out of 5 report involvement only on the face, and 1 out of 4 patients only on hands. If we focus on the location of skin disease, in this slide you see that the most common location, and I told you this before, was for face, after hands, and the other part of the body have visible lesion only for 42% of all population. If we focus on gender, the highest prevalence on skin disease was found on hands in men, and we also found a higher prevalence of skin disease on face in women. And this could be explained probably by the fact probably men are more involved for manual or physical work, and probably for the face localization in women, why not by the use of facial cosmetic. If we go into the hand locations, again, we see that the back of the hand was the most common location from the visible lesions, followed by the fingers, and after the palms of the hand, but 10% of all the respondents reported having nails involvement, which is very important. Again, if we go into gender, dermatosis on the back of the hand reported more significantly by women than by men, but there were no gender difference for the other locations. If we go into face location, the cheeks were the most frequent location overall. The ears and the lip were the less frequently reported location for visible disease, visible skin lesion, And dermatosis on the chin were reported significantly more by women than by men. And locations on the ear and the scalp were significantly more reported by men. There was no gender difference for the other locations. If we go to the second part of the study, which is about the burden and the handicap of visible skin disease, what these slides show is that, again, if we go beyond the location in both face and hands, if we focus only on hands and face, what we observe is that we have a higher proportion of subjects with visible location on the hands, consider the dermatosis as a handicap and in their emotional and intimate life as compared with a subject with a visible location on the face. And we have the same similar result for work life and social relationships, because more subjects with a visible location on the hands reported a functional handicap in their professional and sport activities compared with subjects with a visible location on the face. If we go into the quality of life, and the quality of life was assessed in this study by the DLQI, we all know that the score of DLQI, when it's higher than 10, means that we have a very important impact of quality of life and a huge impairment of quality of life. And again, the DLQI higher than 10 was noticed for 32% of subjects with a visible location versus only 14% without a visible location. And again, the quality of life was more impaired when the visible location was on both hands and face, followed by location only on hands. In terms of stigma, again, the feelings of stigma were greater for subjects with a visible location of the disease on hand. In other words, we can explain this by the fact that the location on hands can elicit disgust or even fear of contagion in the person who is in front of you if you have such lesion. If we compare again the burden and handicap between hands and face, first of all, the handicap of lesion on hands is very important in the daily activities. We have here in the slides example of the way how it is difficult when you have lesion on hands to use your phone, your laptop. But beyond this, a higher proportion of subjects with a visible location of the hands consider the dermatosis as a handicap in their professional, their leisure, their sport activities, but also in their social relationships and in their emotional and intimate life as compared with subjects with visible localization of the disease only on face. So if we go into the synthesis of all this, Visible study is the first one to assess the prevalence of dermatosis loculated in a visible area of the body. This study demonstrates the high burden of visible skin disease on the multidimensional aspect of subject daily lives. The presence of the skin disease on visible area impairs twice as much the quality of life. The localization of the skin disease on the hands be more daily life disabling than localization on face and of the rest of the body. And simultaneous damage to the hands and face systematically amplify the disability, whether it be professional, personal, family, or intimate.